Assalamualaikum and good evening, everyone. Thank you for joining us tonight for this very important webinar. My name is Dr. Ashley Faizah Binti. I'm one of the medical officers at the National Cancer Society of Malaysia. So tonight's topic is about breast cancer, the importance of early detection. So for your information, 50% of breast cancer women in Malaysia is diagnosed at a late stage, stage 3 and 4. And for this, we have invited Dr. Normayah Binti Kitan. She is a new visiting consultant general breast and endocrine surgeon at Columbia Asia Hospital in Puchong. Dr. Normayah brings extensive experience in managing breast and endocrine conditions, providing consultations and performing surgeries with care. She is skilled in laparoscopic and advanced thyroid procedures, ensuring faster recovery for her patients. Additionally, she has contributed to national guidelines for managing breast and thyroid cancers. She also offers a comprehensive range of procedures, including breast cancer surgery, thyroid and parathyroid surgery, and adrenal surgery. So thank you, Dr. Normayah, for being here tonight with us. I think we can go straight into the topic. Doctor, can you tell us about breast cancer?
Okay, breast cancer is the most common cancer in Malaysia and also worldwide. Um, it's affecting women, 1 in 20 women among Malay, and in a Chinese population, the incidence is higher, 1 in 13, and among Indian, it's about 1 in 18. The incidence is higher after postmenopause ladies, and but in our country the incidence has two peaks. One is at the age of 40s and another one is at the age of 50 to 60s.
So you've mentioned how common it is breast cancer to have in Malaysia, Malaysian women. But how about men, doctor? Can men get cancer, breast cancer as well?
Yes, men is possible to have, but it's very uncommon. The incidence about 1 in 100 patients, so about 1%.
Right. Okay. So I want to ask you, doctor, what is breast cancer? Because people still not really sure what breast cancer is. Tell us about breast cancer in general, and I guess we can talk about the signs and symptoms of breast cancer as well.
Okay. When you talk about cancer, so cancer is characterized by uncontrolled growth, and also the cells is has the ability to spread to other organs or surrounding structures. So and for breast cancer, majority arising from the duct of the breast, means the milk pipe. Yeah. And the symptoms, signs, most common is patient presented with breast lump, and most of the time there is no pain. So it's a painless breast lump which is increasing in size gradually within a shorter period of times. And other symptoms, associated symptoms, sometimes patients can present it with nipple discharge, and usually the discharge that is worrying if it's occurred in single breast, in one side of the breast, in a single duct. If it is occur both side in the multiple duct, usually it is physiological. Yeah, and other symptoms like distortions of the breast, uh, puckering of the nipple, and also sometimes patient can present it with enlarged the lymph node in the armpit.
Mhm.
Yeah.
Yeah. Okay. And then, so those are the signs and symptoms that we can look up for.
Mm-hmm.
What about risk factors for cancer, doctor?
Okay, the risk factors you can actually divide into modifiable and non-modifiable. So the non-modifiable is if you are born as a female. So if you are female, you have the risk of developing breast cancer. And then as your age increase, yeah, then your risk of cancer also getting higher. The the modifiable risk like obesity, and then smoking, taking alcohol, that is something that you can actually change, to to reduce the risk, like your lifestyle, making sure that you are um, practicing healthy lifestyle, uh, and with a good exercise. So another non-modifiable risk like genetic, but genetic influence only about 10% of of the patients. So majority, this is what we call sporadic. So you don't have any risk factor, but you still can develop breast cancer.
Yeah, true, doctor. So I've heard, I've read that only 20% women with breast cancer, they have family history. So 80% of them
Yeah,
actually don't have
yeah,
family history at all. So saying that
yes,
every woman, we all have breast, we all are at risk of having breast cancer.
sure.
Yeah. Doctor, we mentioned about obesity and sedentary lifestyle and things like that. How about the penyakit tiga serangkai, the type 2 diabetes, the high blood pressure, the hypercholesteremia? Um,
Mm, mm-mm.
People with those conditions, are they at increased risk of breast cancer?
No, they don't have higher risk. But if you have diabetic, hypertension, heart disease, high cholesterol, if you develop breast cancer, then the treatment will be complicated. Yeah, because when you have breast cancer, you need to go for treatment like chemotherapy, targeted therapy, and surgery, radiotherapy. So you need to be healthy.
Mm,
So your blood pressure, your sugar control must be good.
mm, yeah,
So in order for the treatment to be smooth,
yeah,
yeah.
yeah.
Mm.
Yeah, that makes sense. Okay, so we can ask you the next question. I think I want to ask you about the screening method. So we've learned about the signs and symptoms that we should look out for and the risk factors. So now, how do we check for breast cancer? How do we screen for breast cancer?
Okay, so we should teach our girls, yeah, from young, to do breast self examination. This is important. So all ladies, all girls should know how to check their own breast. When to check their breast is after they are completed their menstrual cycle on that month. Yeah. So because during your menstrual cycle, your breast is a little bit engorged, and most of the time it's painful. So that is not a very good time to check your breast. So you should check your breast after you finish you completed your period or your menstrual cycle. This one, everybody should do it on their own. So you should do it every month. So at least you know how is your breast feels like and looks like. Yeah. So you should observe the how does your breast look like, the position of your nipple, the color of the skin. So you do it routinely, and then you will know how is your breast normal, the normal breast feels like. And then if you are if you have symptoms, any symptoms, pain, nipple discharge, skin itchiness, especially around the areola, please come immediately for treatment, for further investigation or further evaluation by the health professional. Especially you should go to the if you don't find any breast surgeon, you can look for any medical officer in your nearby house or nearby hospital for further checkup. And then for asymptomatic patients, meaning you are healthy, you don't have any symptoms in the breast, you don't have strong family history with breast cancer, your father's side, your mother's side, your grandmother's side, your grandfather's side, you ask them no one with cancer, breast cancer or ovarian cancer, and you are not on any hormone replacement therapy. Yeah, so meanings your risk of breast cancer is low. Then start at 40 years old, you should check for screen. I mean, you should do screening for breast cancer. So how you how what is um, the best method for screening for patient who does not have any symptoms? So after 40s, the best is actually doing mammogram. Yeah, mammogram plus minus ultrasound. So if the mammogram could not see clearly, yeah, then most of the time the doctors will add on ultrasound to make the investigations more sensitive, so the pickup rate to detect any lesion will be higher. Okay, so some patients sometimes they might need extra imaging like MRI. Yeah. Okay, so we are talking about those patients, uh, a normal population with normal risk. So normal risk, you should start your screening at 40. Okay, for those uh, women who at high risk. So who are they who are at higher risk? So one, if they have strong family history, yeah, their first generation, their sibling has breast cancer or ovarian cancer, and then their mother's generation or father's generation and the grandparents generation has breast cancer, and another higher risk factor, if one male in the family diagnosed with breast cancer, then she is at higher risk to have a genetic predisposition for breast cancer. So this higher risk group, so they should start screening earlier. Yeah. So at what age you call it earlier? So you should ask your the family members at what age they are diagnosed with breast cancer. Yeah. So if in the family, let's say your mother have breast cancer at 40 years old, so you should the daughters should check at 10 years younger. So at 30s, they should start check for screening breast cancer. And sometimes if the parents or the relatives proven to have genetic predisposition, the most common is BRCA1, BRCA2, then the immediate offspring should also check for the genetic that can predispose them to higher risk of cancer. Yeah, so those with because those with genetic, they have their own pathway for prevention and also for screening. They are in the special group uh, for prevention. Yeah.
So you mentioned self breast examination. So monthly, you do it after you
Yeah.
finish your menstrual cycle. You do it yourself. That one we start as young as 18, I guess, and then you
Mm-mm.
continue until 40. Once you reach 40, you do mammogram every 2 years, doctor.
Depends on the risk. Yeah. So if you are
Okay.
belong to low risk, you can do it 2 yearly. Yeah.
Mm-hmm.
But if let's say you are belong to higher risk group, yeah, like the just now I mentioned, strong family history, you are on HRT for whatever reason, yeah, then it is advisable to do it every year.
Okay. Yeah.
Yeah.
So you mentioned the hormone replacement therapy. So hormone replacement therapy is for menopausal women lah. So
Yeah,
menopausal women who
postmenopausal
experience
woman.
symptoms.
Yeah. Mm-mm,
So they,
mm-mm.
they take that. How about so that one? If you take it long enough, it can increase your risk for breast cancer. How
Yes.
about birth control? Can can that increase risk for breast cancer?
Yeah. It's possible if you take long durations of birth control pills. Yeah.
Okay, yeah. So long duration.
Yeah.
Okay.
Mhm.
All right, doctor. So they've done all this, like say they don't have symptoms at all, but they're doing the screening, yeah? And then they
Mhm.
found to have non-cancerous lumps. Okay, so non-cancerous lumps that's usually reported will be either fibroadenoma or cyst. A lot of the time we just tell them it's nothing, see you again in 3 years' time. But what are the chance that these things turning into cancer? And when is the point where we say you need a biopsy of this one and you need to cut this one out as well for non-cancerous things, etc.
Okay. Most of the lump is actually non-cancerous. Yeah. Most of the lump, if patients presented with lump, majority is actually non-cancerous. So how do you tell? Yeah. So the assessment of lump is actually um, uh, 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 good with using ultrasound. Eh, from the ultrasound findings, actually the ultrasound can tell us whether what is the character of the lump, the shape of the lump, and then the margin, yeah, margin of the lump, and also whether the lump has increase in the blood vessel inside that particular lump. So basically, the radiologist, the breast radiologist, will actually do a scoring, yeah, what we call a scoring of the that particular lump, whether that particular lump is likely to be cancerous or non-cancerous. Yeah. So for cyst, so actually, a lot of lumps also categorized as a simple cyst. So simple cyst the risk of cancer is 0%. Yeah. So we will we know that this simple cyst you don't need follow up. Yeah. So it is easily diagnosed with on ultrasound. By ultrasound, you know this is simple cyst. But complex cyst or solid lesions means there is a growth, but if it is benign, you still needs to monitor. Yeah, because you do not know the behavior. Sometimes you do not know the behavior of this particular lump if you just see at one episode. All right, because there is a certain lump that called phylloides tumor. So this phylloides tumor sometimes on ultrasound can look benign. Even on biopsy sometimes can look benign. But the suspicions of phylloides is by their history. So the history for phylloides tumor, the tumor will grow rapidly. Yeah. So within like 3 months, 1 or 2 months, it grows probably double. So that is not normal. Yeah. So, but for benign lump, it will not grow significantly. It will grow probably like 1 mm, 2 mm within 1 year, 2 years, but it doesn't grow significantly. Then, usually on ultrasound, the repeated ultrasound, the character of the lump, the shape of the lump will look the same. The size probably slightly increase, and we consider it as stable lump. So, if usually we monitor by 2 years. So if 2 years, by 2 years, that particular lump remains stable, then you are sure that this is actually a benign lump. So it is actually important to monitor the lump, even though from the first ultrasound it looks benign. So any increment during these 2 years, significant increment, like more than 20% from the original size, and you need to do something. Either you do a biopsy or yeah, or or removal of the lump.
Sure. Um, some women, they don't like the fact that their breasts have something in it. So, even
Yeah,
if we're being reassured that it's benign, and we say we can do repeated ultrasound making sure that it's benign. For these women, do we encourage them to, okay, fine, don't worry about it, we'll cut it out for you?
well, I mean, you need to convince because so many ladies with have so many lumps. Yeah,
Mm.
sometimes you have like 10 lumps in one breast. Okay, and if because the evaluations you will evaluate individual lump.
Mhm.
Okay, so it is not practical to remove every lumps in the women's breast. So you have to convince them whatever, unless sometimes if if the lump cause pain, yeah,
Mhm.
sometimes benign lump can cause pain, then probably yeah, you that's the reason that is one of the medical reason why you should remove it. But if it's stable, no symptoms, then yeah, convince the ladies that it doesn't need to be removed, all the lumps in the breast.
Yeah, okay, that makes sense. Now, let's go through mammogram. So,
Yeah. Mm.
we know that mammogram for the age of 40 and above, it is the gold standard test for breast cancer screening because it can detect breast cancer early,
Early stage,
even
yeah.
early stage, even before you can feel the lump. So, even before you can
Mm-hmm.
feel the lump. But most women are very scared to have it done because because of the discomfort, the pain.
Yeah.
And
Mm.
what can we do as healthcare professionals, even now talking about it, what can we do to tell them that it's okay, come and do it?
Okay.
What are the things that we can do, doctor?
Yes. The mammogram nowadays with the new technology, we call it 3D mammogram. So it's slightly better than the previous generations of mammogram. So because the way the image produce, they have like thousands of image, so the qualities become better, and you don't need to really like compress the breast so much nowadays. So majority of patients say it's bearable, and then the pain is just about like few seconds. Yeah, and I think part of the process of doing mammogram, uh, it also depends on the the technician who who does the procedure. So they should gentle enough during the procedure. So if they are gentle enough, most of the time the pain is bearable. Yeah, there will be a slight discomfort, but just during the compression. So once the compression release, then there will be no pain. Yeah. So sometimes the pain is because if they are a bit rough, and then probably the compression is on the bone. So that's why the patient has so much pain. So probably they should yeah, they should request or ask for nowadays a lot of major hospital has this 3D mammogram available. Yeah.
I think the other
Uh,
thing that we can tell patient is time their mammogram,
yeah.
maybe not during their
Yeah.
period, right?
That's correct. So probably when their breast is less dense, less soreness after their menses, probably 1 week after their menses is actually the good time to go for their mammogram.
And also to tell them to come with their friends and families, so that they
Yeah.
can come in
Mm-mm.
group, have that,
Yeah.
support,
Mm-mm, mm-mm.
so that things like
Yeah, that's why sometimes during the Pink October, because
ah,
a lot of hospital give a promotion, yeah,
yeah.
so they can, okay, come, we go for uh for screening mammogram, yeah, three or
together.
four of them. Then after that, they can have like high tea or something like that. So
Yeah, yeah,
something
true, true.
fun, so they will
Yeah,
not be so scared.
yeah. I always tell them also, my room is just next to the mammogram room. I've not actually heard anyone crying or screaming, you know. So
Yeah,
it is painful and discomfort lah, but
yeah. So probably,
not to the
yeah.
point
So
of
yeah.
crying.
Mm-mm.
Mm,
So probably I mean, the area for mammogram, the staff, they should
yeah,
be warm enough not to scare patients.
yeah. The other
Mm.
thing about mammogram, which a lot of patients ask, is the radiation. Is it
Mm.
okay, doctor, to have yearly mammogram? Isn't that radiation? So what
Yeah.
do you say
Mm.
about that?
Yes, of course it's radiation, but the radiation is within safe limit. If you do it every year, you should be okay because you are not doing it like every month. So
Mm-hmm.
once a year for that kind of dose that you receive is actually very safe.
Okay. One more
Mm.
thing about mammogram. I think I always heard that, oh, 40 until 70. And then after
Mhm.
70, you can stop. Some women, even 60, they feel that they're old already, then they just stop.
Mm, 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 mm.
What's the new current guideline about the stopping age uh, that you can share with us, doctor?
Well, I mean, if you are talking about the current Malaysian guideline,
Mm-hmm.
so the screening is actually starts from 50 years old. Yeah, 50 to 70. Okay, but the reason why most clinicians advise at 40 because our Malaysian incidence of breast cancer, they have two peaks of age. One is at 40, yeah, the very productive age, and after that, another another peak is postmenopause. So this young age group, if you don't encourage them for screening, then you will have, I mean, you will lost a lot of them.
Mm,
Yeah. So um, by 70, the actually it is not that you should stop screening if you are healthy. Yeah, if you are still very healthy at 70, very productive, and you are still like
good
having I mean,
quality of life.
yes, good quality of life, I think you should continue
Yeah.
do a screening mammogram because nowadays 70s you still like some of them you still probably like working part time,
Mm,
and
mm,
you are
exactly.
still enjoying your life, so you should continue.
Okay. Yes. Okay. Okay, so we'll talk about the screening, the risk factors, signs and symptoms. I guess we can touch on treatment. Okay,
Mm-hmm.
so does breast cancer equivalent to mastectomy, removal of the breast?
Okay.
Because a lot of people can't accept that part of the treatment.
Okay,
Because
this,
breast is like, sexuality
yeah.
symbol, motherhood symbol, womanhood symbol.
Yeah, this is a very good questions. So like 30, 40 years ago, yes. So
Mhm.
once you are diagnosed with breast cancer, everybody has mastectomy. That was ancient history. So nowadays, with the advancement of knowledge and also the advancements of treatment, so it is no more diagnosis, straight away you go for operation. Yeah. So actually the breast cancer, the treatment is depends on the what we call the characteristic of the cancer itself, which is biomolecular subtyping of the breast cancer. So not all breast cancer are the same. Not all patients will receive treatment all the same. It depends on the characteristic of the tumor is of the cancer itself. So how do you know which cancer is aggressive, which cancer is not aggressive? So it is very important. Once the doctor identified or diagnose that you have suspicious lesion, yeah, on mammogram and on ultrasound, it is important to confirm that yes, you are dealing with cancer, but what type of cancer it is. So basically, or generally, there are three types of cancer. One, breast cancer, yeah. One is the what we call hormone positive. So hormone positive usually occur in older age group, and it is the slow progress. So the progression is a little bit slow. So sometimes old lady like 70 or 80 years old, they presented with this kind of breast cancer for the past 2 years, and the size is like probably just increased like 1 or 2 centimeter from the original. Yeah, so it is quite slow in this group. Usually you just, because it's hormone positive, so sometimes they are not fit for surgery or fit for chemo, so you can give anti estrogen, yeah, to block the estrogen. So meaning that the cancer is caused by the estrogen. So estrogen is like their budger, yeah, budger to so that so the cells will grow. So you just stop the budger by giving the anti-estrogen, and the tumor will shrink. So the second one, we call it hormone negative but HER2, HER2 receptor positive. And the third one is every receptor negative. We call it triple negative. The hormone receptor negative, HER2 negative. So these two group, the HER2 and triple negative, they are aggressive. So usually it occur in younger age group. So in these two groups, most of the time you need chemotherapy upfront. Yeah. Why? Because the risk of recurrence is higher. Okay. So in these patients, the HER2 and the triple negative, they they will need chemo upfront plus minus targeted therapy. So for the two, they have, for HER2, they have chemo plus targeted therapy. So they will have this systemic treatment upfront. So what happened? This treatment will shrink or make the cancer disappear. All right. So let's say the patient has like 4 centimeter tumor in the breast, HER2 positive or triple negative. So they have upfront systemic therapy, yeah, chemo or targeted therapy. So the tumor will shrink or disappear. So after that, when they go for surgery, you don't need to remove, you just need to remove whatever residual tumor. So probably from 4 centimeter, it disappear. Then you just remove the the area, the original tumor part, the center. Yeah. So before they go for systemic treatment, you put a marker in the center of the tumor. Right. So once completed treatment, the tumor all disappeared. So you just remove the clip. Okay. So you can preserve the breast. So the patient doesn't need to remove the whole breast. All right. Okay. And the good thing is that you will know whether the patient has complete response to the tumor. Complete response means there is no more cancer uh, uh, available. I mean, everything gone. So there is no more cancer cells. So you call it complete response. Yeah. So you know that this patient will do well. But if they have residual tumor, yeah, so there is a small uh, residual cancer cells, then you can add on other treatment to to make uh, the survival rate better.
Mhm.
All right. So so what does it mean? It means that if initially mastectomy is impossible, if they already presented with bigger lump. So with this systemic upfront systemic treatment, you can make the lumpectomy possible. You can preserve the breast. The possibility to preserve the breast is still there. Yeah. So now the indication of mastectomy is limited. So who are they who need mastectomy regardless whether the tumor disappeared? I mean, regardless, is only for those who has many focal of breast cancer at the same time, multicentric. Yeah, it means that during the mammogram or ultrasound or MRI, you see there are many focus of cancer in the same breast. Then you call it multicentric. So in this scenario, it is not wise to keep the breast because the risk of local recurrence is higher.
So you're talking about in terms of diagnosis, put them into three categories. How about, can you tell us a bit about staging of breast cancer and what are the prognosis or the survival rate?
Okay. So staging of the breast cancer, now the staging has changed. Uh, the new staging system. It is not just the anatomy. Okay, so those days, it is based on the size, the lymph node, and the other organ whether it's involved or not. So you don't consider the biomolecular subtyping. Yeah, because just now I mentioned that hormone positive is a little bit slower. Yeah, so if you have hormone positive compared to those with triple negative, if you compare same size, same organ, yeah, same size, whether it's in same organ involved, actually the outcome is different. You understand or not? Yeah.
Yeah.
So it means that sometimes the triple negative, if they involve lymph node, only you give. I mean, if they are hormone positive, if they involve lymph node, then you give them chemotherapy because it's already like spread to the lymph node. So the risk of recurrence is higher, yeah, for hormone positive. But if hormone positive tumor, it has not involved lymph node, then you don't need chemotherapy. Okay, so you just need surgery plus minus radiotherapy plus anti-estrogen.
Mhm.
However, if you are looking at higher aggressive tumor, HER2 and triple negative, so even though they are only 1 centimeter, huh, no lymph node, but you give them chemotherapy plus minus targeted therapy. Why? Because their aggressiveness. Yeah, because if you don't give them chemotherapy, the chances that it's recur is very high. So that's why nowadays the staging is include the biomolecular characteristics of the cancer.
Yeah.
Yeah, yeah.
And just to tell again the fact that I said, 50% of Malaysian women with breast cancer diagnosis, late
Yeah,
stage.
yeah. Mm-mm.
And
So
in, uh,
late stage means if the tumor is already more than 5 centimeter, yeah, so they are already considered like locally advanced,
mhm,
and they already involve the lymph node. That's we call it like locally advanced, at least minimum stage 3,
mm,
more than 5 centimeter, and a lot of lymph nodes involved. They are already like stage 3. But if they don't have any lymph node involved, they are considered like early stage.
right. And for
Mhm.
the late stage, stage 3, stage 4, what is the survival rate, doctor, for them?
Survival rate, of course, lower. Yeah, lower. But nowadays, with the advancements of medications, yeah, especially the targeted therapy, the immunotherapy, so we have various options for patients. They
Mhm.
are actually doing, I mean, relatively better compared to like 20 years ago
Yeah.
or 10 years ago. Yeah, so you can see some patients who already have, who already diagnosed as stage 4, but they can live many years.
Right.
So yeah, so you never give up on a patient lah.
Mm-mm. Mm,
I would
okay.
say, yeah.
And all these advancement in technology, medication, and whatnot, are they same available throughout? Like in public, it's available in private hospital available.
Okay. So of course, yeah, I mean this targeted therapy, especially immunotherapy, is very very costly.
Mm-hmm.
um it's available in government setting, but of course uh probably not as uh
As
many
readily
as
available.
yeah I mean it is not as readily available, but in public sector sometimes they have ongoing research, yeah, ongoing research, so sometimes they can get a targeted treatment, targeted therapy under research, where they are given a free treatment, free medications, yeah.
Yeah.
um the so so for the public patients, actually a lot of um option also available for them. So not to say that the public hospital is not good. They are
Suboptimal.
actually, yes, it's, they are actually on par with this the treatment.
Yeah. Sure.
Mm.
Okay, doctor. Okay, I think we have gone live for 40 minutes now, doctor. Um, is, there's a few myths lah, which I think the most. Okay, so yes, so we have three questions. I think we can go
Mm-hmm.
through questions. I think we can read the first question. Yeah, from Skylane Creative. Can you explain the difference between a mammogram, ultrasound, and MRI for breast cancer screening?
Okay. So when we want to screen, yeah, because screening is for normal population and they are asymptomatic patients, yeah. So the screening tool must be readily available and cheap, so that it will be a successful. Okay. So ultrasound and mammogram relatively cheap and readily available. Whereas for MRI, it is not, and it is expensive. Okay. So mammogram using is an um, X-ray radiation. So you will see black and white. Huh? Um, the mammogram, the sensitivity become less if the breast is dense. So what is dense? Dense means there are a lot of breast tissue. Yeah, uh, that producing milk, so that when you take a mammogram, so the image is everything looks white because of the breast tissue. So if there is any lump or changes because of the density, sometimes the image will be obscured. Yeah. So that's why sometimes you need to add on ultrasound. So what is ultrasound? Ultrasound, it's using the sound wave as an energy to detect a lump. Mm. Um, but ultrasound, it can only, I mean, it is good if the patient has already a lump, so it can characterize the lump. But early cancer, when it has not formed any lump, but like microcalcification, the ultrasound will miss the the microcalcifications. Yeah. Whereas MRI using magnetic energy to detect alarm, and with contrast is sort of like uh, it gives the not just image but the the functionality of uh, the kinetic. So it's like you can see whether that particular alarm is active or not, because when you do MRI they will give contrast, so they can see whether that particular alarm is active or not active. So in that sense, MRI is more sensitive compared to mammogram and ultrasound, but because of the it is not readily available and it's very expensive, yeah. So relatively, MRI will cost you about 3,000. Mammogram, ultrasound, probably 4 to 500. Yeah. So as a screening tool, you can't give everybody MRI. So it's not logical. Yeah. So that's why MRI only if the mammogram and ultrasound could not give us enough informations, then you proceed with MRI.
Mhm. Thank you, Doctor. Question
Mm-hmm.
number two from Zakwan. Doctor, what are some myths or misconceptions about breast cancer that might prevent people from getting screened?
Mm, one, the myth, yeah. Uh, some patients, I mean, if they are advised, I mean, when they have lump and then the lump is suspicious, so they they don't want any biopsy taken from the suspicious lump, because they say that by taking a sample, by putting a needle into the lump, it might spread the cancer. Yeah, that one, which is not true. All right. And other thing is that once you have cancer, then you will lose your breast. Hmm.
Mm. I think we've covered one is the radiation risk, which we covered, we sort of said that, the radiation is very minimal with mammogram.
Yes,
Because
mammogram
it's
radiation is
worried
very
about
safe.
very safe. Uh, and then the other one that most commonly asked, they say that I've already got a lump in my breast and I know it's benign, it's been checked before. By doing mammogram, when you compress the breast and make it hurt and everything, will it change my non-cancerous lump into cancer?
Cancer, oh, never
Because you
happen.
traumatized it. Never, right?
No,
Yeah,
never happen. Yeah.
yeah, yeah. Yeah, I think that's some of the myths and
Oh
misconceptions.
yeah, another one.
Yeah. Mm,
Uh, in a breastfeeding mother. Yeah, breastfeeding mother. So
mhm,
sometimes the mother notice there is a lump in the breast. So it is not always because of the blocked duct. Yeah. So even sometimes if you go and see any doctor, if they just, oh, don't worry, this is just a blocked duct. Yeah. So don't don't agree with that. So you should have an ultrasound, at least ultrasound, so that the it to make sure that it is not just mixed up. Because sometimes what happened, the sad story, so this young mother lactating breast, and then they have breast lump, and then they just say, oh, just nothing, you just it's just a blocked duct, so just do a massage, but it doesn't go away. So for months, like 3 4 months, 6 months, you just leave it alone, so the things get bigger and bigger and bigger.
mm,
Yeah, so it will delay the diagnosis. So actually sometimes it might be a cancer actually. So be careful in a lactating breast if you have a blocked duct. So make sure you see a proper, I mean, you see doctor and do a proper ultrasound.
Yeah. I think it's important to tell the public that if you do feel a lump,
Yeah,
you cannot just, you
say
have to have
nothing.
a further
Mm.
investigation. You have to
Yes,
have at
yes,
least ultrasound or mammogram, depending on your
yes,
age,
yes,
to find out what it is. You cannot just be
correct.
reassured by some
Mm.
clinic saying there's nothing.
Yes,
Uh,
correct.
yeah.
Mm-hmm.
So we go to the third and last question
Mm-hmm.
from Anggun Anaki. Are there particular groups at higher risk, and how should their screening plans differ?
Yeah. Okay. The special group, what we call the higher risk group, yeah, the higher risk group. So one, if they have proven that they are carrying the genetic, the BRCA1, BRCA2, yeah, or sometimes a certain. Actually, there are many genes, more than 16 genes that makes you become higher risk of cancer. But the popular one is the commonest one is the BRCA1, BRCA2. So if you have proven you have the gene, then you are in this special group because your risk of getting breast cancer is higher. So you have option, yeah, you have option. One, you do a prophylactic mastectomy, yeah, with reconstruction. Means because the target organ is breast. Okay, so if you want to prevent and you have that gene, so the risk is like 60, 70%, 50% that at any age you will develop breast cancer. Okay, so because we don't have nowadays, we don't have treatment to treat the gene. We don't have that yet. Unless maybe in future we have technology to treat the gene, then probably uh, there is a treatment. But for the time being, there is no treatment. So your risk is so high. So sometimes you will be advised for prophylactic. Prophylactics means you remove the breast before it's become a cancer. Okay, but if you are not keen, so sometimes they you will be given this anti um, estrogen, yeah, anti-estrogen. But of course, this anti-estrogen has their own side effect if you are young, because you are forced to like become a menopause. So there are other issues on that prophylactic medications. Yeah? So majority of patients, if they don't want this prophylactic mastectomy, then you need to have regular screening. Yeah. So this regular screening differ from the common population, the normal population, because their risk is higher. So if they are younger, so sometimes they will be advised to do MRI every year because the mammogram is not sensitive enough to detect. So their pathway of screening is slightly different from the normal population.
Okay. Thank you, Doctor. I think that's all the three questions that we have for tonight. Okay, I think we can ask from Doctor like a take-home message for our viewers tonight about our title, breast cancer, the importance of early detection. So if you can summarize and give them a take-home message, that would be great, Dr. Normayah.
Okay, so every woman, in fact, everyone, even the men, yeah, should know what is breast cancer. Yeah, and don't scared to do screening of breast cancer because by detecting early, it's actually make your treatment become easier, and you will have more options of treatment, and we can actually your chance to survive is actually or cured is very very high. uh, so not to fear of breast cancer, yeah, because breast cancer is a treatable disease.
Yeah, we say that a lot now. If we
Mm-hmm.
can detect it early enough, it's actually a curable problem, curable
Yeah.
disease.
Uh-huh.
We have a lot of breast cancer survivors because they
Mm-hmm.
survived, if they're treated. So thank you so much for your time tonight, Dr. Normayah. It's a very great
Thank you.
sharing tonight about breast cancers and all that we need to know about breast cancer. So it's still October, so we're still doing
Mm-hmm.
Pink October Breast Cancer Awareness Month. Actually, all around the year lah. So we need to be
Yeah.
aware of this and go for your screening if you haven't done already. If you're 40 and above, please go to your nearby, say the health facilities, clinic
Yeah.
kesihatan,
Mm-hmm.
or NCSM or private hospitals, public hospital, they all have mammogram there. Some of the clinic kesihatan you can even walk in.
Yes. Mm-hmm.
So
Mm-hmm.
go for your mammogram tomorrow. So hopefully we can improve our chances at survival.
Yes.
Yes. Thank you, Dr. Normayah.
Thank you, Ashley. All right. Okay. Good
All
night.
right. Good night.